I'm Mahmood Adil. I work at Department of Health, and I'm a National Quality and Efficiency Advisor and also a visiting professor at Manchester Business School. I'm very keen and passionate that this value-based healthcare is the future. And this is what I'm going to talk in next 15 to 20 minutes so that you and I could get a common understanding that how best we can achieve the value-based healthcare. Let me show you three pictures, and I think these pictures will resonate a number of things to you. This is the first picture. I'm sure almost all of you have seen it in July when we had our Olympics, and we are proud of that. This is what is the glory of the NHS. This is what we showed to almost 4 billion people who are watching live, and 204 countries who are looking towards the UK and thinking that what health services has done in the United Kingdom. Then, this is the picture from yesterday. I took two pictures from the website yesterday. The first picture shows that George Osborne saying the UK austerity measures are going to last for up to 2018, maybe more. And the right side, you can see the IMF, International Monetary Fund, is saying the future is gloomy as far as the finances are concerned. So on one side, you can see the NHS, which was born in July 1948. In July 2012, we showed the rest of the world that what we have achieved. This is the situation now, and this is the future. And you can see that if the way our health behaviors are, these are the challenges we are going to face. This is today, you can see around, and this will be tomorrow. And what is the impact? And the impact you can see, I can just illustrate by one example, the impact on the chronic diseases in England. And this is the story all across the globe. And because in developed countries, chronic disease is becoming more common, and in developing countries, unfortunately, they're having a double whammy. It means they're having a communicable diseases, plus they've got long-term conditions. If you look at the data, you can see that 15.4 million, almost 30% of the population of England, having one or more chronic diseases. 10.7 million, there are people who are in workforce, and I'm sure you can make a correlation that if you have got chronic disease and you are in the workforce, you're taking days off, or you are being treated, it means there's a direct impact on the economy, not only on your health. And the third thing, 70% of the NHS budget is being spent directly or indirectly on chronic diseases. 70% of our hospital beds are occupied because of chronic diseases. What does this all lead to? This leads to this. We have £106 billion, and our needs are, based on what the challenges, health challenges we are having now, is 126 billion. And I think almost everyone knows that we have got £20 billion gap, and we called it so-called Nicholson challenge. Sir David Nicholson said that if we have to achieve in next 3 to 4 years so that we can meet the need of the population. I'm emphasizing the need, not the demand of the population. But I think looking at what NHS have achieved in the past, I think we should be positive and optimistic. These are the challenge line I have just drawn. That first of all, we wanted to make NHS free. We did it by 1974. We wanted to make things effective, clinically effective, and people know evidence-based medicine, and the NICE came on board. And then by year 2002, our waiting list gone to baseline, and I think we achieved our number of targets on waiting lists, and it means access. And the next big challenge for last 10 years were quality. And the quality is defined as safer care, effective care, a care which people like, and they must be content. So if we don't have those three elements, then it means we are not delivering quality. And I think we have done a lot of work in the last 10 years. This is the reason when at Olympics, this NHS logo was so-called blown. I think everyone was looking towards UK saying that we are delivering high quality care. Then came the then came this QIPP challenge, and hopefully, if we can't achieve 20 billion, we will be achieving almost a lot. But the next 30 years is all about value-based healthcare. I'm just giving a very rough estimate that what is value-based healthcare. So this is what we are going to face in future. And this is value-based healthcare, because in the past we have enough resources and we kept on improving quality. But if we are having on one side the chronic disease and challenges, on the other side we are having issues with our finances, not in so-called over here, but all across the globe, then the way forward is that we have to find ways to improve outcome with the resources we have got in hand, and that is in simple called value-based healthcare. I think in the next 10 to 12 minutes, I would like to say that we need to look at what are the key hurdles which we have to cross in order to achieve value-based healthcare. I won't give an in-depth review of those hurdles because this is my day job, but I will try to emphasize few of those. These are the 5 I laid down, but let me start by looking at the first hurdle we need to cross to achieve value-based healthcare. And this is having cost and quality data. I think everyone would agree that if we don't have the information and we can't change that information into knowledge, then we won't be able to make things better, because having data into information and then information into knowledge. But to start, we need to have both cost and quality data. In the past, we had a number of interventions which helped us to improve our so-called number of data streams. But now, the time has come, we need to be thinking how best we can bring cost and quality data together. And this is one example called PLEX, Patient-Level Information and Costing System. And this means that we can look at the patients at the same time how much his quality is improving, but as well as how much cost is being incurred in order to treat that patient. So activity, income, and number of expenditure has been brought together, and this is in simple called PLEX. And why I'm saying PLEX is important? Because what PLEX does, that in every hospital, if I use the word hospital at this point in time, the secondary care, in every hospital, we have got 3 systems. And these systems are clinical systems, patient records, and financial systems. If we can bring them together, we can generate knowledge, and knowledge which could help us to achieve value-based healthcare. And I can give you an example. In England, we are having 285,000 patients falling every year in our hospitals. And this is one typical hospital which we have used the PLEX to look at how much saving we can make. At the same time, we can decrease the number of falls. So the cost of fall in that average hospital was 200,000 per year. And the cost of intervention was about 15,000. And if we even reduced to 50%, we could save 120,000. And this was only possible by understanding cost and quality data and by using PLEX. And why PLEX is getting important, that this is not just the acronym. We are trying to implement across the whole NHS. And you can see the year-on-year basis, the bar is raising. The number of hospitals who have implemented it, it is not mandatory at this point in time, but Monitor and number of other organizations, they are trying to, including Department of Health, we are motivating the frontline people and we are motivating the hospitals. They should implement PLEX and they must use PLEX. And at the same time, that while we're implementing PLEX, we also start working on 2 fundamental questions. At the Manchester Business School, we got a grant, and we are trying to look at the practical questions that how our NHS Trust and commissioners are using PLEX, and how can PLEX be used to achieve value-based healthcare. The answer might take a while, almost 2 years, but hopefully when we get the answer, the finding would be implemented in the NHS. My next barrier or the hurdle is that we need to have clinicians and finance managers working together effectively. And I say engagement. This is the second hurdle or the opportunity in order to achieve value-based healthcare. And why they need to work together? If you look at the left-hand side, that is the traditional model. When I was a clinician working in hospital, that point in time, that was a typical model we applied, that you work on quality and think about the financial impact later, hoping it is positive. I think things have changed. Now we are on the right side. This says the new approach to quality improvement. It says make reduction in waste, unnecessary variation, and cost while maintaining and improving quality. See, it means to create value-based healthcare. And that is the reason if the finance managers are the custodian of finances and the clinicians are the custodian of quality, they must work together to achieve this outcome. We have done a number of things nationally to achieve value-based, to bring the clinicians and finance managers to work together. I do not want to take you into details, but for example, scoping issues. We are trying to build their capacity and capability. The doctors need to understand more about finance, and the finance managers need to understand more about quality, so they need to be upskilled. We are also looking at the example of excellent practices, and we are trying to spread it across with the help of Healthcare Finance Management Association and a number of other organizations. And as well as we are trying to mobilize and motivate those communities so they can understand that this is our common problem. It is not the problem of one particular professional. So they need to work together to look at the variation, and they need to work together to bring it and improve it. And I can just give you that we did a survey to look at the feelings of the finance managers as well as the doctors and the clinicians, that how they see about how they perceive this engagement. And we developed 4 levels of engagement. It means the level 1 is that there is only medical director is talking to director of finance, and there's nothing happening underneath. And the level 4 is all the clinical specialties, they are working together on finance and clinical issues together. So you can see that going from level 1 to level 4 means that we will move in the direction of value-based healthcare. And when we did the survey, we asked the question, and this was the answer. The answer was that at what level you are, finance directors, all those trusts who replied, almost 55% trust, they replied, and out of those, 28% said that is their self-perception that they're level 4. So what we did, as a result of this, after developing those 4 levels, we made a national policy. Department of Health collect information every year on reference cost. Now it is mandatory to declare your level of clinical and finance engagement in that questionnaire. So what does it mean? It means we are trying to change the behavior of the clinicians and finance managers so that once this question is being asked, the chief executive is going to ask the medical director and the finance director, tell me what level we are. So it means we are trying to change the thinking. And the third barrier and the opportunity is the information technology and innovation. And this is about this conference and number of opportunities across the country which are on our way, but we are not able to grab them yet. If you look at our daily life, this is the picture in almost every home, that we use technology day in and day out, whatever we do. But when we look at health services, it's very interesting that health services is going to be the last industry who is going to use the information the way it should be used. And I think that's the reason I say it is a waste opportunity so far. And we need to be thinking at the opportunities, at the technologies, which are going to help us to improve the patient outcome, help us to change information into knowledge, and a number of other things which the clinician and the frontline people need so that we can meet their needs, and by doing so, we would be able to achieve value-based healthcare. If you look at what happened, I remember when I was on call in early 90s, I had that phone. So it was a big, chunky phone I was carrying all the time with me. But look at what happened in the last 20 years. So has the NHS transformed? Have we encompassed those technologies? Because this is what happened to everyone in the public domain. The people are carrying these iPhones and so-called smartphones. But are we able to use those in our health services? So this is the transition we are looking for. And I think in order to do that, we did a review in the NHS that how the innovation is being implemented. But the most important thing which came out of this review, that we need to look at the service intervention and the data intervention so that we can encompass the new technologies to improve patient outcomes. But not only that, we do have a lot of technologies. I'm sure you will see when you go out today over here. But these technologies are not being adopted and they are not being scaled up. So it means the challenge for us is that not only we need to look for new technology, but also to find the number of current technologies which we can scale up. And this is one simple example. I visited one hospital and they took me to this dashboard. And this dashboard was showing me all the beds in that hospital which are being cleaned, which are being occupied, and which have got infection. So it means that they can control the whole hospital system and have an excellent bed management system, which means that we can make a very lean and mean system to have a patient flow. So they were controlling, like you go to the air industry and they've got a controlling tower and they're controlling all the planes, and they were controlling all of their beds by having an excellent visual view. And this is, I think this only happened because of information technology. So this is one example. They were able to show that the average stay at that point in time in that particular ward was 4.5 days. So this is my summary slide for success criteria. If you are industry and you are developing new technology, you most of the time look at possibilities, what this technology can do. You look at the practicality, and then you look at so-called desirability. But most of the time, in my experience, it is happening in the same order. As a matter of fact, it should be happening other way around. Because by the time you go, because this is the last bit, that how much the clinicians and the other workforce need that technology is more important than the possibilities. So it is not about the selling, it is all about the need. So if you start other way around, it means you are going to identify the need well in advance so that you can develop the technology which can bring all those possibilities. And if you're working in the NHS or other private sector, these are the three cases you have to make. You need to have the clinical case. It means that is it going to improve the clinical outcome? Second is the financial case. Is it going to improve the financial outcomes? And third thing is the management case. It means are we able to implement it? That is about the management culture. And then very important is about your leadership role. Why you're sitting here today at this point in time? Because you are motivated to make a difference. Because otherwise you wouldn't be coming over here, because this is a health technology conference, and health is all about saving life, adding value to life. And this is the reason I feel that you need to play your own part to move things forward. And these are few suggestions how best you, either individually or as a part of your organization, you can move things forward. First, get involved. This is the opportunity today that you need to find how to get involved with technology, how to get involved with the concept of value-based healthcare. Overcome all the hurdles. Remember the success criteria I just mentioned. And then you must build effective engagement, public and private, the clinical and finance, and looking at volunteer industry and number of academic centers. And the most important things, that you must spread the best practice. If you have got an idea, you have implemented it, which has improved outcome and they have decreased cost, please do not keep it to yourself. I think you are the custodian of the health of the nation. I think we have to get that idea out and we need to implement it. And if we are able to do that, then that is the way we are able to give the gold medal to the health of our future generations. Because I think we are the merchants of hope. If we are not able to improve quality and decrease costs at this point in time, someone 10 years down the line might not able to get the treatment he or she's entitled to. And I think this is our responsibility that we should deliver it. Thank you.